My name is Susan Jack, and we really appreciate the invitation from Families Canada to spend some time with all of you today. And our goal is going to be to talk about building vaccine confidence and really to think about how can we take the principles of trauma and violence informed approaches to service delivery and apply these to these conversations that can sometimes be very emotional or a little bit challenging when we're delivering services. So, in 2007, more than 11,000 readers of the British Medical Journal, they voted on, what's the greatest medical advances ever across history. And the most important milestone selected was sanitation. Apparently us all having access to clean water and sewage disposal is a good thing for our health. And then the next two medical advances were, the development and use of antibiotics and anesthesia, followed by number 4, the introduction of vaccines. And vaccines in our society and in our populations, they really have a critical role in saving lives, in preventing disease, in protecting others, and in reducing the impact of many diseases on our health status. And I bet since March 2020 and the onset of the pandemic, all of us have probably had more conversations about vaccines with our families, with our partners, with our children, with our friends, with our colleagues, and the people that we work with than ever before. These have been really central conversations in our day-to-day lives. And so both Nadine and I, in coming to this webinar today, we are proponents of public health. And we are advocates for the safe uptake of vaccines as an important public health measure to protect individuals and populations. We've both been fully vaccinated as individuals, and today we really share our insights with you based on our review of the most current evidence on vaccinations. But our discussion today really is more deeply informed by the work we've both done to look at how do we integrate these principles of trauma and violence-informed approaches into different service sectors and into different healthcare contexts. As well, I'm going to be sharing some examples grounded in my experiences as returning to be a public health nurse during the pandemic and working in large vaccination clinics. So even though the safety and effectiveness of vaccines are well established and well studied, we know for many complex reasons that vaccine hesitancy is real. And vaccine hesitancy is when an individual delays or refuses a vaccine despite its availability in our communities. And this is a real concern for society. And even though it's a concern now, it was a concern before the pandemic. In public health, individuals have spent a long time trying to understand how do we promote the uptake of childhood immunizations? How do we encourage young people to receive the HPV vaccine? And every year there's typically conversations about how do we promote individuals, particularly those working in health and service sectors, to go and get their annual flu vaccine. And during the pandemic, again, many researchers turned their lenses to trying to understand why are vaccines such a sensitive topic? Why is there hesitancy to receive something that is a great medical advance that has saved lives? And they look at multiple different factors of why individuals truly may be hesitant. And often these hesitancies are grounded in complacency. And particularly during the pandemic, for so many people, they were managing to address some high priority issues every day: isolation, the loss of jobs, the complexity of feeling isolated while trying to raise, their children. So they became complacent in trying to, book a vaccine appointment. Or there was complacency because many people said, maybe COVID is just like a cold. So why, maybe the risks of getting COVID are so low that we don't need the vaccine. Or maybe for many individuals, that vaccine hesitancy is really grounded in the convenience of getting a vaccine or the inconvenience. How to book appointment? Do they want to wait on a long lineup? How do they get to the clinic? How do they make their way through all this information? And I think for many individuals, and particularly for many populations that experience vulnerability in our society, often this hesitancy is underpinned by confidence. A confidence in the vaccine, or more importantly, their confidence or lack of confidence in the systems that deliver them, or in the policymakers or decision makers who are making the decisions about what vaccines are needed, who's delivering them, who is eligible, and when they can get them. So this vaccine hesitancy is a complex issue. Nadine.
Yeah, thanks, Sue. Hi, everyone. Nadine Wathen, and thank you for having us here today. So I get the job of sort of explaining what we call both trauma and violence-informed approaches, or you might hear me refer to trauma and violence-informed care, or TVIC for short, because we have applied this concept in different health and social care systems, and the term care resonates or not, depending on where you use it. So when we implement TVIC in police services, for example, care isn't quite a term that is used in that service. So we talk about trauma and violence informed approaches. So I just wanted to foreground that because you might hear me flip back and forth between different acronyms. So I think, you know, as Susan talked about, especially her last point around that confidence piece, for me, trauma and violence informed approaches in vaccine hesitancy really starts here in terms of understanding the complexity of people's social and political worlds, the systems and structures that guide their opportunities or lack of opportunity in society, conversations that happen within families, relationships, communities, and then what's going on within the individual. And this is a theme that you'll see as we talk about some of the strategies throughout this webinar today, to always maybe push ourselves to move beyond that individual level analysis, that you know, that tendency we might have in a frustrating moment where we're trying to say, you know what, these are safe, they're effective, and someone is maybe not resonating with that message, we might devolve to trying to blame that individual because in that moment we're frustrated with that conversation. And I think what we're trying to say here is, especially in the last few years, but as Sue said, prior to COVID-19, there has been uncertainty. There are many, many complex, difficult to parse out media messages out there. Social media has certainly accelerated a lot of this. As we all know, we can be in our own little social media bubble where we only see the sorts of things we want to see, and we maybe don't have sort of counter information to help us sort things out. So, and it's now become, you know, very politicized. And in some cases, maybe sort of a badge of, you know, what tribe you belong to as to whether or not you're wearing a mask or getting a vaccine and so on. So there's a lot more going on here than people just being uninformed or unable to take in information. And as somebody who sort of came up as an information scientist, you know, I do want to emphasize that it's not just about pushing more and more information at people at this point. There's lots of information. It really is trying to find those moments where you can be empathetic and compassionate and listen to what people are concerned about, and then maybe start to have a conversation that will open up some space for shared decision-making and collaboration. So that's sort of the point with this little wordle that we've shown here, that these things are much broader. And as Susan said, you know, there are many people in our society who might not be confident about receiving vaccines because they've had really bad experiences in our systems, in healthcare systems and education systems, certainly in criminal justice and legal systems. This is actually a little graphic. It's a screen capture from a video that we prepared for another one of our projects on equity-oriented care, which includes trauma and violence-informed care, where people just have nowhere else to go other than, in this case, an emergency department. They don't want to be in the emergency department, but their life circumstances and the things that sort of structure our society, including things like structural poverty, mean that there's nowhere else for them to go, and they know they're going to have a bad experience in that system. So again, starting from a place of compassion and empathy, we try to understand in that moment, you know, why is this person having this conversation with me in this way, and what's really going on here, and maybe not to immediately sort of be frustrated and blame the individual. So this is the reality for many people in our society, that they might not be exactly where they want to be, and they might not have the resources surrounding them that could help support a vaccine decision or another sort of healthcare decision. So Sue, next slide. And, this leads us to a very brief recap of, trauma and violence and how they might be playing out in these interactions. And we have many more resources. Susan and I do full day workshops on this. So I am going to sort of streamline this part a little bit. But as most of you will know, trauma is more than everyday stress. And really it's the experience of, but primarily the response to a negative event or series of events that threatens your safety, your life, or your personal integrity. So it's an overwhelming sort of experience. And that's important. It's more than everyday stress. And when we get into the realm of sort of post-traumatic disorders or post-traumatic stress, we see these as an expected response to these forms of threat, okay? And we talk about fight, flight, freeze, and fawn, and Sue will give us a few examples of what those might look like in an interaction. But the point here is that these are physiological responses. So that when you're under this sort of significant threat to your well-being and your integrity, you actually, the chemistry of your body changes. You produce cortisol, which is a hormone that helps amp you up to be able to deal with the threat. And if you're getting that sort of, if you're awash in that hormone for a long time because the threat is ongoing or chronic, that will actually change your physiology. And it can indeed change your epigenetics. So it can actually change the way that your genes are able to express themselves. So it's not just all in your head, it is brain, body, mind, everything together. And it is grounded in physiology. Okay. So this is a slide with just some examples of the sorts of traumatic experiences that we might be talking about. I think there are 3 points I want to make from this slide. Many forms of trauma are situational or one-off. So there might be a natural disaster. Certainly, we've just had to watch the news for the last couple of weeks to see the sort of horrific climate disasters we're having in the east coast of Canada, in Florida, et cetera. So a single event that can be very devastating. They can be things like job loss, obviously, war, genocide, being a refugee, these sorts of things that are experienced by many newcomers to Canada. And these are what we call situational trauma. The trauma is about an event or something that's going on in your life, primarily externally caused. Interpersonal forms of trauma are usually chronic and complex. So rarely are they a single event. Things like child abuse and neglect are often multiple events. Intimate partner violence, which is an area of research that Susan and I do quite a lot, and how children are exposed to or experience IPV in the home. So these are things that are more on the interpersonal side. And I would say that one of the distinguishing features is they really affect our ability to form trusting attachments to other people. So if you've experienced these forms of interpersonal trauma or violence, it's hard for you to trust people. So linking back to that point Sue made about confidence, if your ability to trust has been very rationally, eroded because of these sorts of experiences, having confidence in others is difficult for you. And that's might be what you're seeing when you're having that sort of encounter with a client or somebody using your service. So a trauma response, sorry, I just had one more point to make on that last slide, Sue, which is the piece at the bottom. Traumas can happen to individuals, but they can also happen to us collectively. And I would say that the last few years have been a collective trauma that has had unequal impacts on different groups in our society. And certainly other historical forms of trauma and ongoing effects of those traumas, like colonialism and residential schools, would be impacting our Indigenous people, for example. So thanks, Sue. Next slide. So again, it's not the event per se that determines whether something is traumatic, but a person's experience of the event or events. And your ability to cope will be shaped by factors both within you, including the past experiences that you've had of trauma and violence and what reserves you have in place, but also those things around you, your resources, your social circles, the things that can help protect you from the worst parts of those experiences. So I think that's an important point as well. We're not just individual islands trying to cope with things. We are either supported or not supported in various ways, and we bring that into those encounters. And again, these forms of stress can be acute, resulting from that single event, as I mentioned, or complex from repeated experiences. And that's something that's important to understand also when we're thinking about how trauma appears in our interactions. And it will differ between people and groups, and it will differ based on a whole myriad of factors. I think an important point is you don't need to go digging to know what happened to people or what's still happening to people. The point is that if you take a universal approach, understanding that about 75% of Canadians have experienced one or another form of trauma that would meet a threshold for post-traumatic stress, it's everywhere. And we should approach people as if, we need to have kid gloves for everyone. We need to be compassionate. Next slide, please, Sue. And this sort of brings us to another really important point, and why we've sort of put the V in TVIC, and that is to really help us focus on structural forms of violence. As I mentioned, there are sort of collective and ongoing forms of violence that exist, that are built into our systems. And that's really what we mean by structural. This is structural. It's not meant to be a sort of an esoteric academic term. It really is about, these are things that are built in. So I've got a little graphic here about poverty. We know that poverty is far too high in Canada, and many children live in poverty. They don't have enough to eat, etc. Racism, other forms of stigma and discrimination, ableism, all of these things cause harm. And as we've learned over the last few years, they are built into our systems. We have discriminatory practices around race. We have discriminatory practices around, poverty and how much a minimum wage is, for example, or how much disability benefits are, or welfare benefits. And those structure people's ability to be financially secure. So it's really understanding that these are ongoing conditions of people's lives that are beyond their control. They really are built into our structures and systems. Next slide, please. So the V, and we usually talk about sort of the big V, which is structural violence, but also the attention to interpersonal forms of violence as particularly harmful forms of trauma, as I mentioned, that sort of erode our ability to attach to people, safely and effectively. This is what the V brings. It really extends on what we call trauma-informed practice or trauma-informed care to bring in those broader social conditions that be impacting our well-being. And to really think about those forms of violence and how they might be operating in people's lives. It's also important to understand that how people respond to trauma might be expected, even if it's not particularly healthy. So if people have experienced lots of trauma over their lives and they use substances to cope with the pain, the emotional and physical pain of those trauma experiences, that is not unexpected. And maybe we can be empathetic instead of being judgmental about people's use of substances and try to find a path such that the harms of those substances are reduced. I think it's important to, again, understand that interpersonal forms of violence like intimate partner violence and child maltreatment are complex and chronic. And these affect people's lives. We talk about intergenerational cycles of violence. So it's difficult if you've grown up in a very violent home to not have some of those patterns repeated. People do, they survive and thrive, but it certainly adds additional burden. And I think the most important point here in terms of those interactions with people is when you bring in that V, you really shift the focus from what's wrong with people, like what's wrong in their heads. It's sort of what happened to them that's made them this way now, to really what's happening and is still happening in a person's life. So what are the conditions of their lives that might have brought you to the moment where you're having an interaction with them that is not going the way that you had hoped. So we have developed 4 principles of TVIC, next slide, please, which are really highly adaptable. As I said, we've used them in everything from police services to healthcare services to education and so on, and have a new handbook coming out later this fall that will talk about all of that. And really it is to understand trauma and violence and how they impact people's lives with that focus on structural and systemic forms of violence, to create safety. And this is incredibly important. Both the provider and the person using the service need to feel safe in that encounter. And that has to happen both at the organizational level and the individual level. And I'll reflect towards the end on the organizational factors. But this also means actively countering stigma and discrimination and starting with your own potentially implicit biases or other judgments and stereotypes that you might bring to an interaction, and really being aware of those and how they might play out and be harmful to a person that you're providing service to. And then the third one is to really focus on collaboration and connection and listening to people so you understand what meaningful choices look like. So it is not actually an authentic choice to say to somebody, oh, you need to go use this very expensive service that's on the other end of town. If that person doesn't have transportation, childcare, or money, they're not going to be able to access that service. So you will only learn what are authentic and realistic choices by listening and having a conversation and really letting the person lead that decision-making process with you as a guide through that. And importantly, finding the person's strengths, because people come to us with many strengths, and then building on those strengths. And again, collectively deciding what skills now does this person need that I could help them develop to now get to the next step in their journey towards making a vaccine decision, having better financial literacy, whatever it is that the next step is, start with their strengths and actively sort of co-create a plan for next steps. And I think that's the end for me, Sue.
Okay, great. Thanks, Nadine. So Nadine's given us, that broad overarching overview of what trauma and violence informed approaches are. And I'm now going to take these principles, primarily, about being trauma aware, finding opportunities for choice and to create connections with clients, the ideas of prioritizing emotional and physical safety and building on strengths, to begin to share with you what are some strategies you can use in sensitive or challenging or difficult conversations about vaccines. And I think actually many of these tips and strategies that I'm going to share with you today, while I'll give examples around conversations with vaccines, these tips and strategies can be used in any conversation where emotion starts to occur and you start to sense, ooh, I think I've stepped into something that might be sensitive or difficult for the client or the individual I'm working with to have a conversation or engage about. Now, in my work, and I'm sure in the work that all of you are doing, many of you have experienced that sometimes we just think we're just asking a simple question. And that simple question provokes a reaction that completely derails the conversation. Perhaps it derails the entire appointment, or even the relationship that you've established with the family or the client or the individuals that you're working with. Now, in the last year, I recently called our family physician's office to get a prescription renewed for my 20-year-old son. And, he's away at school. He was living in residence. It's the pandemic. He's not an online learner. He's stressed trying to figure out online learning and go to some of his hybrid classes. He was also working part-time. He was working in a job where he couldn't use his cell phone during the day. So he tried on his own to get his prescription renewed, but he was on hold. He couldn't use his cell phone. And so I said to him, you know what? I've got a little bit more flexibility to be put on hold. And I'll call during office hours and I'll call and get your prescription renewed. So I call the family's physician's office and the receptionist answers. I just say my need. Hi, I'm calling for my son. We just need this prescription refilled. There's silence. So I'm assuming she's looking something up on the computer. And then her immediate response was, he's over 18. He needs to call. Why isn't he calling to take care of this? This is his issue. And I'm like, oh. And so I explained to her what I just explained to you about the complexities of accessing their office during office hours. And she goes, well, that needs to be his problem to learn to figure out. And in that moment, I felt immediately judged. I'm like, okay, I'm a bad mom. Am I rescuing my son again? Am I not encouraging him to be independent? And in my response, I'm a little bit embarrassed, but I was reactive. I was defensive. I was a little bit snarky. I did talk down to her, and the rest of the call was really rocky. And ultimately, I ended up doing a workaround and contacting the pharmacy to contact the physician and to go a route of faxing. And this reminds me that, so much of our work is about conversations and how conversations are central to the work that we do with our colleagues, with the families, with individuals, with everyone that we work with. And conversations involve the sharing and receiving of information. And conversations are fundamental to relationships. And in the service sector, the goals of our conversations are often to get to know families, to collect information about their history, to ask them what are their current needs, how can we support, and then we often ask more questions to ascertain details about, their suitability or eligibility for a program. And so we perceive that sometimes we're just asking some questions that are pretty neutral. We just need some information so we can do the next steps to help the family. And we make an assumption that these questions are neutral because we need this information to help them. But the reality, though, is that clients come into these conversations with their own histories of trauma, with their own expectations, their own opinions, their emotions, their positions. And often they're coming into these conversations with us as service providers with their own experiences with different systems and structures. And sometimes they've experienced hurt and harm. And that will influence when they engage with us, how they think, how they feel, and how they behave. So on the surface, we may ask what we think are simple questions. What's your address? What is your household income? Who do your children live with? Are you up to date on your vaccinations? Is your child going to get the vaccination? But sometimes these questions are going to be challenging to a client because of the emotions they have about the topic. And it's difficult for us ever to guess or know what question or topic is going to trigger or activate this type of stress or protective reaction in a client. So just like when the GP's receptionist challenged me and it made me question my mothering skills, I went into protective mode. I went into fight mode. I became defensive. I became argumentative. I spoke a little louder than necessary. And this was my own protective mechanism in response to something that I found to be stressful. So I share these behaviors with you on the slide because as a provider, when you're having a conversation with a client, it's important to recognize that if all of a sudden if a client starts to become defensive or argumentative, or if they start to, flee, they hang up the phone, they walk out of an appointment, they start to, grab all their papers or their bags or get the kid ready and they're ready to walk out. Or maybe they start to freeze in the conversation and you start to hear things like, oh, I can't remember. I don't know. They're just saying to you, I don't know in response to your questions. Or they just shrug their shoulders. Know that these are our first cues that this is a sensitive or stressful topic for that individual or client. And we have to then be really careful of our reactions in these conversations, because remember, conversations are about sending and receiving. And often, just like the receptionist at my GP's office, their reaction is, to snap back or even to threaten a client. Well, you know what, if I don't have this information, we can't get you the services that you need. Or sometimes we even become a little bit authoritarian if we're not recognizing this as a trauma response. You must do this, or you need to get this for your child, or CAS might become involved. But when we start to react this way, then what we are unintentionally doing is we're contributing to a situation where the client will start to feel unsafe. They're going to experience more hurt and harm. They're going to shut down even more. And they're going to be less likely in the future to want to engage with you or your services. So instead, anytime you start to see any of these behaviors or reactions, and often you'll know because all of a sudden you'll start to go, oh, I'm feeling a little bit frustrated. Instead of becoming frustrated, what you need to do is to put your trauma lenses on. Because when we see, observe, or hear any of those protective mechanisms, that indicates that a client is experiencing traumatic stress. So we need to pause. We need to take a breath, put these metaphorical trauma lenses on, and view this conversation or interaction through the lens of trauma awareness. And Nadine's already given us some tips of what does this mean. And to me, it fundamentally means that we reframe our thinking. We're not like, in our head going, like, what's wrong with this person? Going, don't they recognize that if they don't get their child immunized, then they're not going to be able to go to school, and then there's going to be more paperwork, or if the mother doesn't get her vaccinations, then she might not be able to return to work, and she's already stressed about finances. No, we reframe our thinking. We don't go down there of what's wrong with this person. Instead, we start to go, oh, I see how this person is reacting. I see that that is a stress response. They're protecting themselves. And so I wonder what has happened to them in the past. And again, as Nadine said, the majority of people have experienced a trauma or traumas in their past or ongoing. So we go, okay, I'm assuming that this is just how they respond to these traumatic situations or these stressful situations. And again, this is a red flag that maybe they've experienced a trauma. Again, I don't need to know the details. It's enough for me to see these behaviors and use those as a cue to change my behaviors. And so I need now to carefully ensure that as we continue the conversation and the appointment or the encounter or the home visit, that I do everything in my power to prioritize the client's sense of emotional and physical safety. So how am I going to do that? Well, as I said to you, my background is in public health nursing, and so I always like to think about prevention. So what can I even do in any encounter before someone has that stressful response? And one of the approaches that I really loved, it's taken from Alberta Health Services, is the nod approach. With every new encounter with a colleague, with a client, with anyone else accessing your services, or even if you're on a home visit and you're meeting a new family member or friend, to use the nod approach. And that means in every first encounter, you tell them your name, your occupation, and your duty, or what's going to happen today. And you also provide really clear expectations around what's going to happen next. This helps to reduce people's sense of anxiety if they really know what's going to happen next. What are we talking about? How long is this going to take? What information are you asking me about? Who gets access to this information? So when I was working in the vaccine clinics in the hockey arenas, as soon as someone sat down in my chair at my desk, the very first things I always said is, hi, my name is Susan. I'm a public health nurse. Thank you so much today for coming to get your vaccine. You know, I'm going to take a few minutes to ask you some questions about how you're feeling today and your health history, because that information is going to help us make some decisions about, which vaccine or if you get the vaccine today. And then I'm going to give you lots of time to ask me any questions that you have. And then if you consent, we'll proceed to administering the vaccine and then talking about, your aftercare. So that was always the start, right? Telling them who I am, what's going to happen, framing what's going to happen next. Other things to think about is often you're going to be working with families and asking questions that are more of a sensitive and personal nature. Well, you know what? Please give families a heads up. Today I'm going to be asking you some questions on this assessment or screening tool, and some of these questions are personal and sensitive. And the reasons we ask these important questions are because, and tell them why you're asking these questions. And then let them know that if at any time it's difficult for you to ask these questions or answer these questions, we can take a break, we can pause, we can do it on another visit or appointment. So always think about prevention, how we can start conversations before someone becomes stressed. But undoubtedly, you will have conversations where things are going along fine. And all of a sudden, during the course of the conversation, some topic comes up. Again, we can never predict what it's going to be. You notice that there's starting to be an emotional response from a client. And as soon as you start to see some of those reactions, their behaviors or what they're saying or doing starting to come, quickly do a quick check-in of yourself and start to moderate your own behaviors. We want to offer a response that is calming and promotes a connection with the individual. These are called mirror neurons, and that's a type of brain cell that responds equally when we either perform an action and when we witness someone else perform the same action. So for example, if one of my kids goes to the fridge, opens up the fridge, takes out a carton of milk, and then they sniff it and they go, "Ugh." If I'm standing in the kitchen, I'm going to have that same reaction, and I'm going to wrinkle my nose in disgust and go, oh, just come on, throw it away. So these mirror neurons, we physiologically can mirror each other's responses. And so we want to apply this process here, but to calm individuals. So if you sense that a conversation is becoming charged or the individual is approaching the encounter already with an emotion, whether it's anger or frustration or fear, we need to modulate our behavior. When I was in those vaccine clinics, I could tell from 20 feet away when someone was walking across the arena to sit in my chair if they were anxious, if they were afraid, if they were having a bad day, if they were a teenager who had been coerced by their parent to come. You can see that in their body language. And now the other big cue was often when they would sit down next to my little table and they would pull their chair like 5 feet away from me or slump down or cross their arms. So in those situations where I wasn't sure yet what the emotion was, but I sensed anxiety, fear, ready to challenge me, I would immediately move away from my desk, turn to them face to face, and I'd really slow down my speech, my own speech. Instead, I'd be like, instead of like, "Hi, I'm Susan, I'm your public health nurse," I'm like, "Hi, thank you for coming today. My name's Susan. I'm a public health nurse here at the health unit." And I would start to slow down my own breathing. I wouldn't tell them, "Oh, take a deep breath." I'd start to slow down my own breathing and my own speech and introduce pauses and give them time to engage. And very often through those mirror neurons, you would start to see them start to relax. It was easy in a clinic too, because we often had juice and water on our tables. And I could quickly just even say, "It's really hot in here today. Can I give you both, a bottle of water?" Start to give them some water just to sip and slow down their breathing. So this is one of the first things that you can do when these conversations start to become challenging. Moderate your own behavior. Yes. Okay. And in these conversations, it can sometimes, especially if we're talking about vaccines, we always say to people, don't be judgmental when you're working with clients or individuals, but it can be really hard. And I know it's been hard for me at times having conversations with different family members or different people in the community when their values and beliefs about vaccines are fundamentally different than mine. It's hard for me not to be judgmental, to go, "Gosh, I think they're going to put their own health or someone else's health at risk if they don't get the vaccine or wear a mask." So I know it's hard not to be judgmental. But when we're having conversations with the people that we are working with, that we are hired to serve, it's really important that we put our judgments aside and our own assumptions. And instead, we actively listen to the message and stories they're sharing with us. That when there's emotion, that we listen with compassion. That we approach the dialogue not with judgment, but with curiosity. It's our goal to really understand what has happened to you in the past. What's happening here? What experiences have contributed to the emotions that they're feeling now? And I think the other key strategy is how we listen. In many conversations, people are often listening to the other person, but they're listening until the other person gives a break. And as soon as there's a break, they jump in with their own information. And often it's like, "Well, here's why you should do it. And here's all the information about vaccines that you should know." But instead, I think we need to train ourselves better to not just be listening to respond and put our thing in, but instead be really focused on listening to what the person is saying. And so that our goal of our listening is to learn from them, to learn what they're saying, what their experiences are, and not just listening so that we can jump in with what we think is the solution. So when we're listening to learn, what we're actually doing is what's called reflective listening. And reflective listening for anyone is a valuable skill to refine. And I think many of you probably work with the parallel process. Reflective listening is also a great skill to teach parents to use when they're talking to their children. And reflective listening focuses on really gaining a deeper understanding of an individual's story, their narrative, what they're feeling. And we use reflective listening to strengthen and to facilitate building a connection with the other person. So reflective listening primarily involves you first to think reflectively about what the individual is saying, the meaning of what they're saying, and then we respond with a statement to check the meaning, rather than assuming that we already understand what they're saying. And at this stage, a well-formed statement as opposed to a question is actually less likely to evoke a defensive reaction or a defensive response, and it's more likely to facilitate engagement in the conversation. So you can create a statement to share back with them, something that reflects what they've been saying through their words, the emotions that they've been expressing, or that reflects some of the behaviors you're observing in the encounter. And I've got some examples here on the slide. And when we're having these sensitive conversations and we're doing reflective listening, it might be your gut instinct to want to respond to vaccine hesitancy, to ask a why question, just to ask them why, like, why haven't you taken your child to get their COVID vaccine? Or why didn't you follow up on that appointment you made with public health to get your second booster? We want to ask why questions, but I'm going to suggest to you too that please use a reflective statement. Please don't ask why questions. Often individuals actually can't articulate answers to why. And instead, if we ask a why question in those charged conversations, their responses tend to be of those protective responses of fight, flight, freeze, or fawning. And again, they may become defensive, shut down the conversation. So try not to ask why questions. Put a reflective statement. If you need to start to ask some questions, focus on asking what or how questions then for a more gentler or more respectful approach to getting more information. So for example, what information do you require to help you make a decision about getting a vaccine for you or your child? Now, as you have these conversations, as clients begin to feel safer with you, they may choose to share with you when a past experience has been difficult or challenging. A client may feel safe to open up to say to you, I am terrified of getting my vaccine. And at a past appointment, I fainted and it was so embarrassing. Or a client may say, you know what? They just can't. One time their child was being restrained while getting a vaccine, and they just can't stand the thought of their child crying or experiencing pain. So when clients share with you something that has been difficult for them, our primary response in the conversation, again, needs to be to listen, actively and reflectively listen, and then to validate their experience. Acknowledge, it is okay to acknowledge that their experience has been difficult. Fear of needles is a very real thing. And when we're thinking about the harms that people have experienced in systems, we may also find ourselves that we need to validate and acknowledge that some individuals do not feel safe when they're seeking care from our services or seeking care to receive a vaccine. So, when we reach this point, it's so important to validate and then to begin to identify what matters most to them and to respond with deep empathy and compassion and sit and listen rather than always rushing in again with facts and information to try to immediately solve a problem. And in having these conversations, the words that we use matter, particularly when we're talking about vaccines. And when we use language that's strength-based and positive, this really helps again to promote emotional safety for clients. So we really need to pay attention to those words. Identify client strengths. Thank you for asking me questions today, or thank you for raising this topic and allowing us to have a conversation. That's a strength right there. And specifically, if you're having conversations about vaccines, try to use words like poke, pressure, or squeeze rather than, hurt, pain, sting, or shot. Find that language that, creates a better sense of safety. But the other thing too is when we're having these difficult conversations, we do need to be honest and we do need to be transparent about what they can expect. So we don't want to use language that's going to amplify their fears, but we do need to be honest that, we might say, yes, when you get your vaccine, it may be uncomfortable for a few minutes, but it's going to go away. And here are the things that we can do, to help ease that discomfort. And I'd also like to learn from you, what are the things that you have found in the past have made it easier for you to get a vaccine. Okay. I'm going to quickly finish up here. The other strategies. The other things that we can look for in these conversations, once we've listened, we've validated, we've taken the emotion, we've de-escalated the emotion, at some point, you're probably interested in providing some support or service to a client as part of this encounter. And one thing I've learned is that I never make the right guess or assumption of what a client or family really needs. And so it's always really in our best interest to ask the client, okay, we've just had this conversation. If there was one thing I could do before the end of this appointment or this home visit or this encounter, if there's one thing I could do to support you to take the next step to meet your most immediate need, what would that be? And have them tell you what is their most immediate need. Have them identify their priority need or concern. Because again, service providers, healthcare providers typically think it's like you just need more information or you need a referral. But usually for people, it's something completely different. So ask the question, what is it if there was one thing you could do? And then in your response, to support them to address that identifying need, remember, it's not our job to fix the problem, but we can do some other things. We can build on their strengths. If they are asking for more information or they are hesitant to get the needle because of needle fear, well, acknowledge, well, you're already asking questions. That's really important to taking that next step. Offer support. Okay, if that's your need, is there something I can do to help support you? What are those options, right? So if you need more information, if you want to know the strategies to address a fear of needles, what are some options? Can you call your family physician's office? Can we call public health? What are some options? Present some options. And then often in our work, our next step is then to refer the individual or the client that we're working on to another agency or specialist. And I think the days are really gone of us just handing a name and a phone number to a client and saying, oh, you follow up and give them a call. Instead, I really encourage support workers, family home visitors, nurses, social workers, anyone, whoever you may be, to really do a warm referral process. And that's really where you support the person through that process of connecting with another agency. Maybe it's by helping them develop a list of questions or looking up the phone number or thinking through what's going to happen when they contact the other agency. Now, all of this work to apply these strategies in a trauma and violence informed way at the level of your work with a client can only occur if you work within organizations that also value trauma and violence informed approaches.
Yeah, thanks, Sue. So this next to last slide is really emphasizing that point that in our work, and I've got a link here at the bottom for Equip Healthcare work, an action kit to actually help organizations implement trauma and violence informed approaches hand in hand with cultural safety and anti-racism strategies, as well as harm reduction and substance use health strategies. So on the right in this box is really guidance for organizations to make sure that individuals can act in ways that Susan has outlined. Often that means, giving people a little bit more time and some flexibility in how they use their time and judgment to take a bit of extra time to have an interaction that supports a person who might be struggling in that moment. So the organization has to present the conditions under which individuals can practice in a trauma and violence informed way. And that means having a pretty close look at what's currently going on. It means talking both to those closest to the work, so your direct service providers, but also those who use your services, because they can tell you maybe where things could be improved. So I won't go into these in detail just because of time, but can refer you to Equip Healthcare and especially our Equity Action Kit. Next slide. And for those of you who want to learn more about TVIC, we have a freely available online e-learning curriculum, and the URL is at the top. Again, you access it through the Equip Healthcare webpage. You register for the learning management system, which is housed at the University of British Columbia. It takes about 8 hours to do in total, but it's non-consecutive. You can come back, you save, you have a notebook. to gather your reflections and to link you to additional resources. So those of you interested in this approach, I certainly would recommend this resource, and you'll see lots of us doing videos and providing lots of practical strategies and tools. And that really is it. I think our last slide just has a few more links to the sorts of resources that you can access to support this way of practice.